Sepsis is the deadliest condition affecting seniors, killing over 270,000 Americans annually, with adults over 65 accounting for approximately 70% of all sepsis cases and 80% of sepsis deaths. Sepsis occurs when the body's response to infection becomes dysregulated, causing widespread inflammation, organ damage, and circulatory collapse. Without immediate emergency treatment, sepsis progresses to septic shock, with mortality rates exceeding 40 to 50%, even with aggressive intensive care, including mechanical ventilation, vasopressor medications, and continuous renal replacement therapy. What most seniors and their families don't realize is that commonly prescribed medications dramatically increase sepsis risk through multiple mechanisms, including suppressing immune function, preventing effective infection fighting, damaging organ function, making the body less resilient to infection stress, altering normal protective bacteria, allowing dangerous pathogens to flourish, impairing the body's ability to mount appropriate inflammatory responses, and masking early infection symptoms, causing delayed recognition and treatment. As infectious disease physicians and critical care intensivists who have treated thousands of sepsis patients over 40 years of combined practice in emergency departments and intensive care units, we've learned that medication-related factors are among the most important and most overlooked contributors to sepsis risk in older adults. We routinely see elderly patients admitted with severe sepsis or septic shock who are taking multiple medications known to increase infection and sepsis risk, yet neither they nor their prescribing physicians recognize these medications as dangerous. By the time sepsis is diagnosed, these patients are critically ill, requiring emergency interventions that are less effective because their medication-compromised immune systems cannot fight infection adequately. The statistics are sobering. Research published in Critical Care Medicine found that seniors taking certain high-risk medications had 2 to 5 times higher sepsis risk compared to those not taking these drugs. More concerning, sepsis occurring in patients on these medications carried 40 to 60% higher mortality rates because immune suppression prevented effective infection control even with antibiotics and supportive care. Many of these deaths were potentially preventable if medications had been discontinued, doses reduced, or alternative safer treatments used. Sepsis risk increases dramatically with age due to immunosenescence, the progressive decline in immune function. The thymus gland, producing T cells, shrinks by 70 to 80% between ages 20 and 70. Neutrophil function declines, reducing ability to engulf and kill bacteria. Antibody production decreases. Cytokine responses become dysregulated, either inadequate or excessive. These age-related changes make seniors more susceptible to infections and less able to control them before they progress to sepsis. Adding medications that further suppress immunity or impair organ function creates a perfect storm. A 70-year-old with naturally declining immune function who then takes corticosteroids suppressing immunity by another 50 to 70% has drastically reduced ability to fight infections. A simple urinary tract infection that a healthy person would clear easily becomes urosepsis, requiring ICU admission. A minor skin wound becomes cellulitis, progressing to bacteremia and septic shock. The tragedy is that many of these medications are prescribed for non-life-threatening conditions that could be managed alternatively. Seniors take proton pump inhibitors for mild heartburn when dietary changes would work. They take corticosteroids for joint pain when physical therapy and other approaches are safer. They continue broad-spectrum antibiotics for weeks when shorter courses or narrower agents would suffice. Each prescription made without considering sepsis risk represents a missed opportunity for harm reduction. Research from JAMA Internal Medicine examined medication use in seniors hospitalized with sepsis. Studies found that 60 to 70% were taking at least one medication known to increase sepsis risk, and 30 to 40% were taking two or more such medications simultaneously. The risks were additive. Patients on multiple immune-suppressing or organ-damaging drugs had exponentially higher sepsis rates and mortality compared to those on single agents. In this comprehensive video, we'll examine 5 commonly prescribed medication classes that dramatically increase sepsis risk in seniors over 60, with medication class number 3 being the most dangerous, increasing sepsis risk by 200 to 300% and taken by over 15 million older Americans, many of whom don't need it and could use safer alternatives. These aren't rare specialty drugs. These are medications millions of seniors take daily, often for years or decades, without understanding the serious infection risks. Understanding these risks allows informed discussions with physicians about whether these medications are truly necessary, whether doses can be reduced, whether treatment duration can be shortened, or whether safer alternatives exist. Complete medical references appear in the description. Now let's examine the 5 medication classes that most dramatically increase sepsis risk in seniors over 60 and what you can do to protect yourself. Medication number 5. Proton pump inhibitors for acid reflux and GERD causing gut dysbiosis and pneumonia. Starting at number 5 are proton pump inhibitors, or PPIs, including omeprazole, esomeprazole, lansoprazole, pantoprazole, and rabeprazole, used by over 20 million Americans for gastroesophageal reflux disease, peptic ulcers, and heartburn prevention. PPIs are among the most commonly prescribed medications in adults over 60, with approximately 25 to 30% of seniors using them chronically, often for years or decades. Yet research shows that long-term PPI use increases infection and sepsis risk by 40 to 70% through multiple dangerous mechanisms. PPIs work by irreversibly blocking the hydrogen-potassium ATPase enzyme, or proton pump, in stomach parietal cells, dramatically reducing stomach acid production by 90 to 95%. While this effectively treats acid-related symptoms, it creates serious unintended consequences. Stomach acid serves as the body's first line of defense against ingested pathogens, including bacteria, viruses, and parasites. Normal stomach pH of 1.5 to 3.5 kills most pathogens within minutes of ingestion. When PPIs raise stomach pH to 5 or 6, bacteria pass through the stomach alive, colonizing the small intestine and colon. Research published in JAMA found that PPI users had 65% increased risk of Clostridioides difficile infections, severe gut infections causing profuse watery diarrhea, abdominal pain, and toxic megacolon requiring emergency colectomy. C. difficile spores survive stomach acid, but vegetative bacteria normally don't. PPIs allow vegetative bacteria to flourish. Studies showed that PPI users had 200 to 300% increased risk of recurrent C. difficile infections because disrupted gut microbiome couldn't prevent recolonization. PPIs dramatically altered gut microbiome composition, a phenomenon called dysbiosis. Normal protective bacteria, including bifidobacterium and lactobacillus, decrease by 40 to 60%, while potentially pathogenic bacteria, including Enterococcus, Streptococcus, and pathogenic E. coli, increase 10 to 20-fold. This dysbiosis impairs gut barrier function, increases intestinal permeability, or leaky gut, and allows bacterial translocation, where gut bacteria enter the bloodstream, causing bacteremia and sepsis. Studies examining sepsis risk in PPI users found 40 to 50% increased risk of gram-negative bacteremia from gut organisms and 25 to 35% increased pneumonia risk from aspiration of oral bacteria that normally would be killed by stomach acid but survive and cause lung infections in PPI users. Community-acquired pneumonia risk increased 50%, and hospital-acquired pneumonia risk doubled in hospitalized seniors taking PPIs. Perhaps most concerning, research in critical care medicine found that seniors taking PPIs who developed sepsis had 20 to 30% higher mortality rates compared to non-PPI users with sepsis. The mechanism involves impaired immune responses. PPIs directly inhibit neutrophil function, reducing ability to kill bacteria by 30 to 40%, independent of acid suppression effects. This immune suppression, combined with dysbiosis, creates a perfect storm for severe infections. The tragedy is that 50 to 70% of chronic PPI users don't have appropriate indications for long-term use. Studies found that many seniors started PPIs during hospitalizations for stress ulcer prophylaxis, a practice that's only indicated in ICU patients on ventilators, then continued them indefinitely after discharge, despite no ongoing indication. Others take PPIs for mild intermittent heartburn that could be managed with lifestyle changes, antacids, or H2 blockers, which don't suppress acid as completely and carry lower infection risk. What you absolutely must do if taking PPIs chronically is discuss with your physician whether you truly need them. Appropriate long-term indications include Barrett's esophagus, severe erosive esophagitis, gastronoma or Zollinger-Ellison syndrome, and prevention of NSAID ulcers and high-risk patients. Inappropriate chronic uses include mild GERD responsive to lifestyle changes, prophylaxis against stress ulcers in non-ICU patients, and treatment of dyspepsia without documented ulcer disease. If you don't have appropriate indication, work with your physician to discontinue PPIs. Stopping suddenly causes rebound acid hypersecretion lasting 2 to 8 weeks, where acid production temporarily increases above baseline, worsening symptoms. Taper gradually over 4 to 8 weeks, switching to H2 blocker like famotidine for 2 to 4 weeks, then to antacids as needed. Address lifestyle factors, including losing weight if overweight, avoiding large meals within 3 hours of bedtime, elevating head of bed 6 to 8 inches, and eliminating trigger foods. If you have legitimate indication requiring chronic PPI use the lowest effective dose. Many patients take 40 milligrams twice daily when 20 milligrams once daily works adequately. Consider drug holidays. Use PPIs for 8 weeks, then try discontinuing for 4 weeks to see if symptoms recur. Some patients can transition to on-demand use, taking PPIs only when symptoms occur rather than daily prophylaxis. Every dose reduction or day without PPIs reduces cumulative infection risk. Medication number 4. NSAIDs, including ibuprofen and naproxen, causing kidney damage and immune dysfunction. Medication number 4 comprises nonsteroidal anti-inflammatory drugs, or NSAIDs, including ibuprofen, naproxen, indomethacin, ketorolac, and COX-2 inhibitors like celecoxib, used by over 30 million Americans for pain, inflammation, arthritis, and fever. NSAIDs are available over the counter, leading many seniors to assume they're completely safe, but chronic use dramatically increases sepsis risk by 40 to 80% through kidney damage, immune suppression, and masking of infection symptoms. NSAIDs work by inhibiting cyclooxygenase, or COX enzymes, that produce prostaglandins mediating inflammation, pain, and fever. However, prostaglandins serve critical protective functions, including maintaining kidney blood flow, protecting gastric mucosa, and regulating immune responses. Blocking prostaglandin production causes serious adverse effects. The most dangerous effect is acute kidney injury. Prostaglandins normally dilate afferent arterioles entering kidney glomeruli, maintaining adequate blood flow for filtration even when systemic blood pressure drops. NSAIDs block these prostaglandins, causing afferent arterial constriction, reduced glomerular blood flow, and declining glomerular filtration rate. In seniors with baseline kidney disease affecting 30 to 40% of adults over 70, NSAIDs can precipitate acute kidney failure within days. Research in Kidney International found that NSAID use increased acute kidney injury risk by 70 to 100% in adults over 65. The risk was highest in those with chronic kidney disease, heart failure, liver disease, or taking diuretics, ACE inhibitors, or ARBs, all conditions and medications extremely common in seniors. Studies showed that 10 to 15% of hospitalizations for acute kidney injury in older adults were directly caused by NSAIDs. Why does kidney injury increase sepsis risk? Kidneys are essential for clearing bacteria, toxins, and inflammatory mediators from blood. When kidney function declines, these substances accumulate, overwhelming immune defenses. Additionally, uremic toxins accumulating in kidney failure directly impair neutrophil function, reducing bacterial killing by 40 to 60%. Seniors with NSAID-induced kidney injury who develop infections cannot clear bacteria effectively, allowing rapid progression to sepsis. NSAIDs also suppress immune function independent of kidney effects. They inhibit neutrophil chemotaxis, reducing ability of these critical immune cells to migrate to infection sites. They impair macrophage activation and cytokine production. Animal studies showed that NSAIDs increased mortality from bacterial infections by 200 to 300% through immune suppression, even in animals with normal kidney function. Perhaps most dangerous is that NSAIDs mask infection symptoms. Fever is the body's primary warning signal of infection, prompting patients to seek medical care. NSAIDs powerfully suppress fever through prostaglandin inhibition, allowing infections to progress undetected. Studies found that seniors taking NSAIDs chronically who developed serious infections, including pneumonia, UTIs, or intra-abdominal infections, delayed seeking care by 24 to 48 hours on average compared to non-NSAID users because they didn't develop fever. This delay allowed infections to progress to sepsis before antibiotics were started. Research in critical care medicine examined NSAID use in seniors who develop sepsis. Studies found that chronic NSAID users had 50 to 70% increased sepsis risk and 30 to 40% higher sepsis mortality compared to non-users. The mortality increase persisted even after adjusting for kidney function, suggesting direct immune suppression contributes to worse outcomes. The tragedy is that many seniors take NSAIDs chronically for conditions manageable with safer alternatives. Osteoarthritis pain, the most common indication, often responds well to acetaminophen. Topical NSAIDs applied directly to painful joints, avoiding systemic effects, physical therapy, weight loss if overweight, and joint injections. Yet millions take oral NSAIDs daily for years because they're convenient and available without prescription. What you must do if taking NSAIDs regularly is reassess whether you truly need them. For acute pain lasting days to weeks, including post-surgical pain or injury, NSAIDs are appropriate short-term. For chronic pain, including osteoarthritis, try alternatives first. Acetaminophen at 3,000 to 4,000 milligrams daily, divided into 3 to 4 doses, provides effective pain relief without kidney toxicity or infection risk for most patients. If inadequate, add topical diclofenac gel or cream applied to painful joints. Topical NSAIDs achieve high local concentrations at joints with minimal systemic absorption, providing pain relief without systemic side effects. Consider non-pharmacological approaches, including physical therapy, focusing on strengthening muscles, supporting arthritic joints, occupational therapy, teaching joint protection techniques, weight loss, reducing mechanical stress on joints, heat or cold therapy, and braces or supports. If these approaches fail and oral NSAIDs are necessary, use the lowest effective dose for the shortest duration. Ibuprofen 400 milligrams 3 times daily is safer than 800 milligrams 3 times daily. Taking NSAIDs 3 days weekly is safer than daily use. Avoid indomethacin and ketorolac, which carry highest kidney and GI toxicity risks. If you have kidney disease, heart failure, or take diuretics, ACE inhibitors, or ARBs, avoid NSAIDs entirely. Risks far outweigh benefits. Medication number 3. Corticosteroids, including prednisone, causing severe immune suppression, the most dangerous medication. Medication number 3 is corticosteroids, including prednisone, prednisolone, methylprednisolone, and dexamethasone, the single most dangerous medication class for sepsis risk, increasing infection and sepsis risk by 200 to 400% and sepsis mortality by 50 to 80%. Approximately 2 to 3 million Americans over 60 take corticosteroids chronically for conditions including rheumatoid arthritis, polymyalgia rheumatica, COPD exacerbations, asthma, inflammatory bowel disease, and various autoimmune conditions. Many more receive short courses for acute conditions. While corticosteroids are life-saving for certain severe conditions, they carry extraordinary infection risks that many patients and physicians underestimate. Corticosteroids are synthetic versions of cortisol, the body's natural stress hormone that suppresses inflammation and immune responses. While this makes them effective for treating inflammatory and autoimmune diseases, it also cripples the immune system's ability to fight infections. Corticosteroids suppress virtually every aspect of immune function through genomic and non-genomic mechanisms affecting gene transcription and cell signaling. At the cellular level, corticosteroids inhibit production of inflammatory cytokines, including tumor necrosis factor alpha, interleukin-1, and interleukin-6, that are essential for coordinating immune responses against infections. They reduce circulating neutrophils and monocytes by redistributing them from bloodstream into bone marrow and lymphoid tissues, where they cannot reach infection sites. They impair neutrophil chemotaxis, phagocytosis, and bacterial killing. They suppress lymphocyte proliferation and antibody production. They impair macrophage activation, preventing effective antigen presentation to T cells. The result is profound immune suppression. Studies measuring immune function in patients taking prednisone 20 milligrams daily found 40 to 60% reduction in neutrophil bacterial killing capacity, 50 to 70% reduction in lymphocyte proliferation in response to antigens, and 60 to 80% reduction in antibody production. Patients taking higher doses of 40 to 60 milligrams daily had immune function comparable to AIDS patients with CD4 counts below 200, essentially no functional immune system. Research published in JAMA examined infection risk in corticosteroid users. Studies found that prednisone at doses above 10 milligrams daily increased serious infection risk requiring hospitalization by 200 to 300%. Risk increased in dose-dependent fashion. 5 milligrams daily increased risk 30%, 10 milligrams increased risk 100%, 20 milligrams increased risk 200%, and 40 milligrams or higher increased risk 400 to 500%. Even low doses of 2.5 to 5 milligrams daily, considered physiologic replacement, increased infection risk by 20 to 30%. Duration of use also mattered enormously. Using corticosteroids for less than 2 weeks carried relatively low risk. Using for 2 to 4 weeks doubled infection risk. Using continuously for 3 months or longer increased risk 5 to 8-fold. The effects were partially reversible. Stopping corticosteroids allowed gradual immune recovery over 3 to 6 months, though some deficits persisted for years. The types of infections seen in corticosteroid users reflect the severe immune suppression. Common bacterial infections, including pneumonia, urinary tract infections, and skin infections, occurred 3 to 5 times more frequently. Opportunistic infections, rare in healthy individuals, became common, including pneumocystis pneumonia, disseminated fungal infections, including candidiasis and aspergillosis, reactivation of latent tuberculosis, and severe herpes zoster infections. Most concerning for sepsis risk, corticosteroid users who developed infections progressed to sepsis much more rapidly because immune systems couldn't contain infections. Studies found that corticosteroid users who developed pneumonia progressed to septic shock, requiring ICU admission at rates 3 to 4 times higher than non-users. Mortality from sepsis was 50 to 80% higher in corticosteroid users, even with appropriate antibiotics, because their suppressed immune systems couldn't clear bacteria. Additionally, corticosteroids cause hyperglycemia by increasing hepatic glucose production and causing insulin resistance. Blood sugars rise by 50 to 100 milligrams per deciliter on average, with some patients developing steroid-induced diabetes. Hyperglycemia directly impairs neutrophil function. Studies show that elevated glucose reduces neutrophil chemotaxis, phagocytosis, and bacterial killing by 40 to 50%, further increasing infection risk beyond direct immune suppression. What you absolutely must do if taking corticosteroids is work with your physician to minimize exposure. Many conditions treated with steroids can be managed with steroid-sparing immunosuppressants, including methotrexate, azathioprine, or biologics that may carry lower infection risk. If corticosteroids are necessary, use the absolute minimum effective dose. Many patients take 10 to 20 milligrams daily when 5 milligrams would control symptoms adequately with much lower infection risk. Taper as quickly as safely possible. Many patients remain on corticosteroids for months or years because physicians fear disease flares with tapering, but prolonged use guarantees serious infections. Aggressive tapering schedules, reducing by 1 to 2.5 milligrams every 1 to 2 weeks, minimize cumulative exposure. If taking corticosteroids chronically, ensure vaccinations are up to date, including pneumococcal vaccines, annual influenza vaccines, and Zoster vaccine before starting if possible, since live vaccines cannot be given during immunosuppression. Be vigilant for infection symptoms. Seek immediate medical care for fever above 100.4 degrees Fahrenheit, productive cough with colored sputum, urinary symptoms, or any sign suggesting infection. Corticosteroid users cannot afford to wait and see if symptoms improve. Infections can progress to sepsis within hours, requiring immediate antibiotics. Medication number 2. Broad-spectrum antibiotics causing C. difficile and resistant organisms. Medication number 2 is prolonged or repeated courses of broad-spectrum antibiotics, including fluoroquinolones like ciprofloxacin and levofloxacin, third and fourth generation cephalosporins like ceftriaxone and cefepime, carbapenems like meropenem, and combinations like piperacillin tazobactam. While antibiotics are essential for treating serious bacterial infections, inappropriate overuse paradoxically increases future infection and sepsis risk by 60 to 100% through destruction of protective microbiome, selection of antibiotic-resistant organisms, and C. difficile infections. The human gut contains over 100 trillion bacteria, comprising 500 to 1,000 species that perform essential functions, including preventing colonization by pathogenic bacteria, synthesizing vitamins, metabolizing medications and toxins, regulating immune function, and maintaining gut barrier integrity. This microbiome establishes during infancy and remains relatively stable throughout life unless disrupted by antibiotics. Broad-spectrum antibiotics kill not only the pathogenic bacteria they're targeting, but also 70 to 90% of normal protective gut bacteria. After a typical 7 to 10-day course of broad-spectrum antibiotics, microbiome diversity decreases by 50 to 70%, with some species eliminated completely. The microbiome gradually recovers over 3 to 6 months, but never fully returns to baseline. Studies show persistent alterations years after antibiotic exposure. This disrupted microbiome creates colonization resistance breakdown, where absence of normal bacteria allows pathogenic bacteria to flourish. C. difficile spores are ubiquitous in healthcare environments. Normal gut bacteria produce metabolites preventing C. difficile germination and growth. When antibiotics kill protective bacteria, C. difficile germinates, multiplies, and produces toxins causing severe colitis with profuse diarrhea, toxic megacolon, and sepsis. Research in New England Journal of Medicine found that 30 to 40% of antibiotic-associated C. difficile infections progressed to severe complicated disease requiring ICU admission, emergency colectomy, or resulting in death. Mortality from severe C. difficile colitis exceeded 20 to 30% even with appropriate treatment. Seniors over 65 accounted for 80% of C. difficile deaths. Beyond C. difficile risk, antibiotic use selects for resistant organisms that persist in the gut and can cause future infections difficult or impossible to treat. Fluoroquinolone use selects for extended-spectrum beta-lactamase-producing Enterobacteriaceae resistant to most oral antibiotics. Carbapenem use selects for carbapenem-resistant organisms resistant to essentially all antibiotics. These resistant organisms colonize the gut asymptomatically, then cause urinary tract infections, pneumonia, or bloodstream infections months or years later that don't respond to standard antibiotics, rapidly progressing to sepsis. Studies examining sepsis outcomes in patients colonized with resistant organisms found 40 to 60% higher mortality compared to those with antibiotic-susceptible infections because empiric antibiotics chosen at sepsis presentation didn't cover resistant organisms, allowing 24 to 48-hour delay in appropriate treatment while bacteria multiplied and caused organ damage. What you must do is avoid unnecessary antibiotics. Studies show that 30 to 50% of outpatient antibiotic prescriptions are unnecessary, prescribed for viral infections, including upper respiratory infections, bronchitis, and sinusitis that don't benefit from antibiotics. Question physicians who prescribe antibiotics for colds or viral symptoms. Viral infections should improve within 7 to 10 days without antibiotics. When antibiotics are necessary, insist on narrow-spectrum agents targeting the specific pathogen. Many physicians reflexively prescribe fluoroquinolones or broad-spectrum cephalosporins because they cover wide ranges of bacteria. But narrow-spectrum agents like amoxicillin for pneumococcal pneumonia or nitrofurantoin for uncomplicated UTIs work equally well with far less microbiome disruption and resistance selection. Limit antibiotic duration to the minimum effective course. Many infections previously treated for 10 to 14 days now have evidence supporting 5 to 7-day courses with equivalent outcomes. Shorter courses reduce microbiome damage and resistance risk. Medication number 1, SGLT2 inhibitors causing genital infections and urosepsis. The number one medication class that surprises most people by dramatically increasing sepsis risk is SGLT2 inhibitors, including empagliflozin, dapagliflozin, and canagliflozin, relatively new diabetes medications also used for heart failure and chronic kidney disease. While SGLT2 inhibitors provide cardiovascular and kidney benefits, they increase genital and urinary tract infection risk by 200 to 300% through mechanisms promoting bacterial growth. SGLT2 inhibitors work by blocking sodium glucose transporter 2 in kidney proximal tubules, preventing glucose reabsorption and causing glucose excretion in urine. Blood sugar lowering by 30 to 50 milligrams per deciliter improves diabetes control, but glucose in urine creates perfect bacterial growth medium. Research found SGLT2 inhibitors increase genital yeast infections by 300 to 400% and urinary tract infections by 50 to 70%. More concerning, they increased urosepsis risk, severe infection starting in urinary tract progressing to bloodstream causing sepsis and septic shock. Fournier's gangrene, necrotizing fasciitis of perineum in genitals with 20 to 40% mortality, occurred 10 to 20 times more frequently in SGLT2 inhibitor users. What you must do if taking SGLT2 inhibitors is maintain excellent hygiene, stay hydrated, and seek immediate care for any genital or urinary symptoms. These 5 medication classes dramatically increase sepsis risk in seniors. PPIs, NSAIDs, corticosteroids, broad-spectrum antibiotics, and SGLT2 inhibitors all impair immune function or create infection-promoting conditions. Review medications with your physician to minimize these risks. Which medication were you taking? Share in comments. If this helps someone avoid sepsis, please share. Subscribe for life-saving medical content. Thanks for watching.